You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 22nd, 2022. This week, I want to talk about a response to therapeutic fashion, early rhythm control of atrial fibrillation, statins in chronic kidney disease, and salt intake in heart failure. First topic is I want to thank Canadian cardiologist Dr. Vartan Mardigan, who so perfectly enhanced my written discussion last week of therapeutic fashion. Now, here I am in the post going on about how medical norms get established based on dubious data or even in the absence of data. And Vartan replies to me on Twitter, knowing full well that I am entranced by conduction system pacing. Quote, do you think that left bundle pacing would qualify as therapeutic fashion, or do you think that the benefit can withstand critical appraisal? You have also adopted left bundle pacing prior to the results of the RCTs. I immediately quote tweeted him back and said that I love this, and I do. First of all, my friends, please always challenge me. I am a mere private practice EP doctor whose hobby is reading and writing and trying to communicate medical evidence. This podcast, All Critical Appraisal, is about content. Always judge the content. Remember, I'm just John, the AFib ablation doctor from a little hospital in Louisville, Kentucky. Second point is, as a practicing doctor, of course I'm susceptible to therapeutic fashion. And in the case of conduction system pacing, which produces the most gorgeous ECGs ever, we have pragmatic challenges. First, we're unlikely to have large trials. And this is because in cardiology, and EP particular, industry is the major funder of trials. And industry only funds trials that have a confluence of interest. In other words, industry funds trials that could increase market share of their product. And this is not nefarious. It is how we got saline irrigated catheters, ICDs, BIVs. Industry-funded trials can lead to benefits for both society and industry. The problem with conduction system pacing is that it uses less expensive existing pacer generators, like a simple dual-chamber pacemaker generator versus a biventricular generator, and it uses established pacing leads. If conduction system pacing were found non-inferior to BIV pacing or cardiac resynchronization therapy in a trial, or if it was shown to prevent pacing-induced cardiomyopathy in a trial of conduction system pacing versus RV pacing, then industry would sell fewer cardiac resynchronization therapy devices. So there's no confluence of interest. So we'll have to rely on government funding or self-funding. For instance, the HISSYNC trial was self-funded. And if you haven't noticed, government has a lot of health problems to study, and I'm being realistic here that conduction system pacing may not be one of their top priorities. The second point in the case of conduction system pacing is that we have pretty good data that when HISS bundle pacing is successful, it does provide resynchronization and is quite similar to standard BIV pacing. Yes, of course, the clinical outcome data is lacking. But remember, cardiac resynchronization therapy is just a simple electrical therapy of left bundle branch block or left ventricular delay. HISS bundle pacing seems equal to the task as electrical therapy. But HISS bundle pacing has challenges. There's difficult to place these leads. The thresholds are higher. There's often low sensing. So that's where left bundle pacing comes in. Left bundle addresses these weaknesses. It's much easier to do, and the pacing parameters are great. And I also love the fact that when you do left bundle pacing, at least when I do, I use a 3830 pacing lead, which has a proven track record for more than a decade. And this track record means a lot to me because newer pacing leads may be better, but they may be worse. And we've been burned in electrophysiology many times with these new and improved pacing leads. Now, finally, there's also early data suggesting that the resynchronization that one gets with true left bundle pacing is similar to his bundle pacing and CRT, but the emphasis here is on early. While there remains much to learn about pacing in the left bundle area, these are the reasons I feel comfortable adopting it as a strategy. And I admit that we need to stay humble, gather data, and try our best to promote trials. And thanks again, Vartan, and to everyone, always challenge me. Okay, next topic is early rhythm control and atrial fibrillation. Jack has published a pre-specified analysis of the EAST-AF-NET trial looking at whether the type or pattern of AFib modifies the efficacy of early rhythm control. The authors distinguish three types of AFib here. First, diagnosis of AFib, paroxysmal AFib, and persistent AFib. Before I tell you the results of the sub-study, let's briefly recap EAST-AF-NET, which New England published in October 2020. About 2,800 patients with relatively new onset AFib, defined as AFib within the last year in duration, they were randomized pragmatically to two strategies, an early rhythm control strategy that included mostly antiarrhythmic drugs. Remember, after 2 years, less than 20% of the early rhythm control group had had an ablation, so this was not an early ablation trial. The usual care group used early rhythm control only to treat symptoms. It was mostly rate control. The first primary outcome was vast, and this included CV death, stroke, heart failure hospitalizations, or acute coronary syndrome, and the second primary outcome was days in the hospital. In EAST-AF-NET, after 5 years of follow-up, the early rhythm control group had a statistically significant 21% lower rate of the composite primary outcome. The days in the hospital did not differ. Now, safety outcomes were reported as similar, but the authors included primary outcome events like stroke and death in the safety outcomes. And if you count only serious adverse events of special interest in the early rhythm control group, it was more than threefold higher. Now, adverse events was one of the problems I had with EAST-AF-NET. The other was that the two groups had a difference in AFib of only 20%. In the supplement, we learned that 80% of the early rhythm control group were in sinus rhythm at 2 years versus 60% of the usual care. So my question is, how can a delta of only 20% of AFib, that little difference in AFib, in patients who are on oral anticoagulation, cause a major reduction in hard endpoints? And the answer to me is performance bias. I'll take quotations from the paper. Quote, patients in the early rhythm control group were asked to transmit a patient-operated single-lead ECG twice per week and when symptomatic. Quote, documentation of recurrent AFib triggered an in-person visit from the site team to escalate rhythm control therapy as clinically indicated. That means that patients in the early rhythm control group got much more interaction with doctors. Again, this is not one bit nefarious. It is no knock on the investigators, many of whom I have the utmost respect for. This is just simply a hurdle for all pragmatic trials that test strategies. So in sum, while EAST-AF-NET produced positive results, I feel like the small delta in AFib, the likely performance bias, and the much higher rate of adverse events related to early rhythm control render the results hard to translate to the average patient. And in Bayesian terms, the results of EAST-AF-NET do not change my prior practice, which was to treat risk factors, use anticoagulation when indicated, give time a chance to heal AFib, and then use early rhythm control selectively. Okay, now to the sub-analysis looking at AFib types. It was about a third, first AF, a third paroxysmal AF, and a third persistent AF. Now, not exactly, but pretty close. The authors report that early rhythm control reduced the primary endpoint in each of these three AF types, but the degree of reduction was least in patients with first diagnosis of AFib, though the P for interaction was non-significant. They then did something very curious. They then delved into the components of the primary endpoint in each AF type. And I say curious because trials are powered for the overall population. And they've already separated three groups by AFib type. Now they're delving further into the individual endpoints of the primary endpoint, which to me seems very likely to get into more noise than signal. And they reported in the abstract as the main finding that ACS events, acute coronary syndrome events, were higher in the early rhythm control group in the first diagnosis of AFib group. And they reported as a relative risk. The rate ratio was 1.5 in the early rhythm control versus usual care in the first diagnosis of AFib group. Now, in the other groups, the paroxysmal and persistence, the rate ratios for ACS was favorable for early rhythm control. They also report that patients with first diagnosis of AFib spent more nights in the hospital than the other groups, and they concluded that early rhythm control reduces the first primary composite outcome in all AF patterns, and patients with first diagnosis of AFib are at high risk for hospitalization and acute coronary syndrome, particularly when they're given early rhythm control strategy versus rate control. Now, my comments. This paper is really problematic to me on so many levels. First, I've been treating AFib for decades, and I have never once thought that treating it in any way prevents an ACS. I mean, ACS, as I see it, is plaque rupture. This is unrelated to AFib. Sure, you could get into demand types of MIs, but I don't think we call that ACS. When you treat AFib, you're trying to prevent heart failure and stroke and relieve symptoms. Now, just having the ACS endpoint in the main East AF trial adds noise, in my opinion. And focusing on one part of a 4-part composite endpoint in this sub-analysis seems really strange, especially since it's the one that's least connected to AFib care. Now, second, even if you allow looking at one component of the endpoint, there were only 27 ACS events in the early rhythm control arm versus 19 in the usual care arm in this first diagnosis of AFib group. So that's a delta of only 8 ACS events in a trial with nearly 3,000 patients. Now, how is that not noise? Third, as for the higher number of hospital days in the first diagnosis of AFib group, this is explained by Table 1, which tells us that these patients were far more likely to be enrolled into the trial as inpatients, whereas paroxysmal and persistent patients were more likely to be enrolled in the outpatient clinic. Now, the one thing I would say, and I agree with editorialist Dr. Emma Svenberg, is that in first detected AFib patients, especially those in the hospital, that should trigger us to look for upstream causes. Recall that AFib is almost always driven by stuff that aggravates the left atrium. In the outpatient clinic, these aggravating factors are usually cardiometabolic stuff like obesity, hypertension, sleep apnea, alcohol. But in the hospital, it could be that plus pneumonia, PE, thyroid storm, or other medical illnesses. So the higher hospital days in the first diagnosis of AFib group is easily explained by the fact that more patients in this category had AFib associated with medical conditions that required a hospital stay. So in sum, this sub-analysis does nothing to change my approach to patients with atrial fibrillation, whether it's first diagnosis, paroxysmal, or persistent. And if anybody has any explanation of why the authors did such an analysis, or if you disagree with my appraisal of this, please let me know. Next topic is rosuvastatin and the kidney. Now, I have a confession to make. I did not know there was controversy over rosuvastatin approval at the time FDA gave its approval. I did not know it had risks of causing blood and protein to spill into the urine, and that it may be associated with an increased risk of kidney failure requiring replacement therapy. Journalist Marlene Busco has written an excellent recap of an observational study published in the Journal of the American Society of Nephrology, and this looking at the association of rosuvastatin with hematuria and proteinuria. And I don't think I've ever reported on a paper from the Journal of the American Society of Nephrology. Now, it turns out that these rosuvastatin effects were likely dose-related, and FDA approved rosuvastatin at doses less than 40 milligrams, but the label also included a comment that the starting dose of rosuvastatin in patients with creatinine clearance less than 30 ought to be 5 milligrams, with titration up to a max dose of only 10 milligrams. So the authors of this observational study harnessed data from an Optum Labs data warehouse, which involved 40 healthcare organizations. They emulated a target trial, which is recommended by the Causal Inference Group of Miguel Hernan, and more on that in future podcasts. The goal of this paper was to assess the association of rosuvastatin versus atorvastatin use with the risk of hematuria or proteinuria, as well as study the dosing patterns in patients who have chronic kidney disease. The methods section of this paper is beyond the scope of my abilities, but the idea behind target trial emulation is to get as close to randomization as possible. And the technique here was something called inverse probability of treatment weighting. Now, someday I hope to understand this as well as I do arrhythmias, and then I'll explain it to you. This was a large cohort of patients, 150,000 patients on rosuvastatin, nearly 800,000 on atorvastatin, the mean age 60 years, and half were women. Now, even before applying the probability weighting, most of the baseline characteristics were similar between the rosuvastatin and atorvastatin groups. And the four findings were that users of rosuvastatin had an 8% higher risk of hematuria, 17% higher risk for proteinuria, and a 15% higher risk for kidney failure with replacement therapy compared with those on atorvastatin, though the kidney failure hazard barely met statistical significance. Importantly, the authors noted a rosuvastatin dose dependence risk of hematuria and proteinuria in patients who had CKD. The two groups avoided MI and stroke to similar events, and 44% of patients with severe CKD, grade 4, were prescribed a higher rosuvastatin dosage than the maximum 10 milligrams per day recommended by FDA. Now, the authors discussed a few things. They speculated on the mechanism of increased blood and protein in the urine with rosuvastatin, and there were lots of complex things, but it may simply be a class effect in that rosuvastatin is renally excreted to a greater degree than atorvastatin, and so, of course, exposure is more than 3 times with rosuvastatin than atorvastatin in those with impaired kidney function. They then write that an initial study suggested similar signals as they found, but it was a small study. Other observational studies have not shown this association, but were limited by small numbers of events. They then discuss a trial called Planet 1, which looks at renal protection in patients with diabetes and proteinuria, and this was atorvastatin 80 versus rosuvastatin 10 or rosuvastatin 40, and the primary endpoint was urine protein. This and other studies found that atorvastatin reduced proteinuria, whereas rosuvastatin did not. The authors were also quite clear and comprehensive regarding their limitations, and obviously the main one, despite the probability weighting without randomization, there still can be unmeasured confounders. For instance, sicker patients get rosuvastatin over atorvastatin. The sample size was large, but the number with creatinine clearances less than 30 was tiny, only about 1% of the study population. So, like the previous study I just talked about, there's a chance for noise. Now, my comments is I learned something here. Most obviously, way too many patients are receiving high doses of rosuvastatin that go against the FDA recommendations. And rosuvastatin compared to atorvastatin surely seems to predispose to kidney toxicity, especially in patients with advanced chronic kidney disease. The hematuria and proteinuria signals are stronger than the kidney failure with replacement therapy signal. So I agree with Canadian nephrologist Dr. Swapnil Hiramath, who commented in the story that we needed more awareness of this phenomenon. And he's probably right in that someone who's on high-dose rosuvastatin and then develops CKD, and it just doesn't get adjusted because it has just been on the drug for so long. And that this is a place where clinical pharmacists could have a great role. Finally, though, let's always remember that statins may not have the same CV protection in patients with at least end-stage renal disease. Remember, 2 important trials, the Aurora trial, New England, 2009, 3,000 patients on hemodialysis, rosuvastatin versus placebo. The drug reduced LDL but had no effect on cardiovascular outcomes. Same thing in the 4D trial. This was New England, 2005. This was atorvastatin versus placebo in patients on hemodialysis with diabetes. Again, no benefits in major adverse cardiac outcomes. Final topic, salt and heart failure, at least heart failure with preserved ejection fraction. Journalist Patrice Wendling has a keen eye for good topics, and salt restriction in heart failure is indeed a relevant, everyday thing we deal with. The journal Heart has published a secondary analysis of the TopCat trial. Now, TopCat was spironolactone versus placebo in patients with HFpEF. This was published in New England Journal 2014. TopCat found that spironolactone did not reduce outcomes, but it was mired by huge geographic heterogeneity and variation in results. Patients enrolled in Russia and Georgia, which are a lot of them, had shockingly low outcome rates. And reanalysis of the trial, excluding those groups, finds that spironolactone indeed conferred benefits in HFpEF. Now, recall also that the recently published pragmatic trial, sodium HF trial, This was published in Lancet, and it found that a strict sodium restriction in outpatients with heart failure did not lead to a reduction in clinical events. So for this sub-study, a research group from China wanted to further explore the idea of salt restriction in heart failure. And they used data from TOPCAT, which is available because it is an NIH-sponsored study. Unlike many industry's trials, there's open data. They excluded the contested patients from Russia and Georgia, and then they studied the association of sodium intake via a self-reported cooking score, which was available on the patient data forms. And they looked at cooking score of salt and outcomes. The primary outcome of TOPCAT was CV death, cardiac arrest, or heart failure hospitalization. And they come up with this cooking score of 0, basically the control arm, so to speak, which meant no added salt in their cooking. And then there were other cooking scores of 1, 2, 3 were given for increasing amounts of added salt. Here are the main results. Compared with patients with a cooking salt score of 0, patients with a cooking salt score greater than 0 had a statistically significant 24% lower risk of the primary endpoint and a 27% lower risk of heart failure hospitalization. Cooking score of 0 was worse. Now, my comments. You don't want to go crazy over a post hoc observational study of an old trial, especially one that uses a self-reported salt cooking score. Plus, the authors dichotomized the results, meaning they used a score of 0 or greater than 0. And to me, that always raises a red flag because I wonder if it would be better to just display the results like continuously. I learned this from following statistician Frank Harrell on Twitter, by the way. But here is another signal, similar to sodium HF, that suggests that we might not be overly restrictive in our salt intake recommendations in patients with heart failure. And I agree totally, though, with commenter Dr. Minnow Walsh, who emphasized that many of these patients with heart failure are volume overloaded, and for sure we should counsel them on not taking in high salt diets. But, of course, there's a big difference between avoiding a high salt diet and like 0 salt. So I think there's probably room to be somewhere in the middle on the low end of salt, but without being so restrictive. Finally, I want to close the podcast on this comment. A lot of post-hoc studies are really misleading or used for spin, but not all of them are. I mean, some are quite valuable. And papers like this one, for instance, are possible because there is open data. And so I believe that all trials that are used for regulatory purposes ought to be open for such analyses. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, give the podcast a rating, write us a brief review. These things help others find us. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.